Thank you. It's a great pleasure to be here. I'd like to present on behalf of our team for the Sydney Survivorship Centre. So we founded the centre in September 2013 to try and give a more holistic care for survivors of adult cancer. And it started with our survivorship clinic, which is what I'm going to focus on today. But then in 2014, we opened the survivorship cottage in the grounds of the hospital, surrounded by nice sort of gardens. And there we run a lot of courses with a real strong emphasis on healthy lifestyle. We're also fortunate to have a survivorship gym. And when we set up the Survivorship Centre, we embedded research into every aspect of this. And that's what I'm going to present on today. So the Survivorship Clinic, our aim is to help for survivors to better manage their disease and any lasting or new treatment effects, and to really facilitate them developing a healthier lifestyle. So the actual Survivorship Centre is for survivors at any stage of the cancer journey, but the actual clinic is for patients that have completed primary adjuvant treatment with curative intent and who are currently disease-free. When we started it in September 2013, we initially just restricted it to survivors of breast and colorectal cancer, and then in 2014 opened it up with a haematology colleague to haematology patients, predominantly lymphoma survivors, and subsequently have opened it up to other solid tumour types. So the model that we selected for care is very much a multidisciplinary clinic. And what I'm going to speak today about is what happens at that first initial visit and the data that we've generated from that. So when the survivors come, they're with us for the whole afternoon, and they see 5 different health professionals. They don't get a choice of who they see. It's a package deal. So one after the other, we wander into the room. There's either an oncologist or haematologist as appropriate. We have a cancer nurse specialist, in most cases someone specific to that tumour type. We have a dietitian, an exercise physiologist, and a clinical psychologist. So you can see why they're there for the whole afternoon. Prior to them coming, each survivor is sent a package of questionnaires, and we're looking at particularly symptoms, quality of life, diet, exercise, and distress. And they're asked to please complete those and bring them back with them to the clinic. And this, as well as being part of our research, is actually standard of care and is incorporated into the clinical visit. It helps us and to make the best use of that time. That's their homework. Prior to them attending, our homework is to create the treatment plan and survivorship care plan. And we then go through that with the survivor and we'll make changes to that as appropriate. We have an assessment which also includes physical examination by the oncologist or the haematologist. But as well as just looking for surveillance of their disease, we're very much focused on what are the side effects and or late effects from their cancer and or their cancer treatment, not just medical but psychosocial as well. An enormous part of the clinic consists of education. We have, as I said, a real emphasis on healthy lifestyle, diet, exercise, but also other aspects of psychological well-being and, if appropriate, ceasing smoking. They're also given a DVD to take home and a booklet from the Cancer Council, and if appropriate, we would then refer on for special expertise, so for example, for sexual health, for what we can't deal with ourselves. So what happens after that? So for about 60% of the survivors, they will then, after we have referred them on or linked them into our different programs, they will just come to us for a one-off session and go back to their regular team. However, for about 40% of the medical oncology patients, we then become their primary team following them up, and they then return. On subsequent visits, they don't see the cast of thousands. Instead, they just see the medical oncologist and the cancer nurse specialist, but it's very easy for us to bring in the other members of the team if there's a particular problem that we need to address. So what I'd like to focus on is presenting data from the first 4 years of what the health status is of survivors at that initial visit. And this is based on the patient-reported outcomes that they complete prior to coming in and that we go through, looking particularly at their symptoms, quality of life, distress, exercise. They also, at the conclusion of the clinic, are asked to fill in a satisfaction survey, which can be totally anonymous. And then we collect clinical data. So staff will measure height and weight for body mass index, and we've also in this case looked at some of the clinical psychologist's recommendations. So in that first 4 years there were 364 new survivors attended the clinic, and here apart from for the demographics where we've used all of those, we've included information on up to 341. So there were 23 for whom either we could not locate their consent form, and just a handful of those who actually declined for us to use their de-identified data. So what have we found? What I've done when I've looked at this to make it easier for you, this is the demographics, but on the first column you'll notice it's for the total for all the patients that we saw, and then I've divided up based on the main tumour types that we've seen, just so that you can split it up there. So the average age was 56, however fairly wide-ranging, younger as you would expect in the haematology age group. 69% were women, but that's mainly driven by the breast cancer group, which was our largest cohort at that time. There were 43% breast cancer patients, 30% colorectal, 20% hematological, and then the 7% of other is mainly actually upper gastrointestinal cancers with a handful of lung cancer, gynecological cancers. Almost all had received chemotherapy, which is actually one of our eligibility criteria for the clinic, but we do make special exceptions where people have really main late-term effects that we're asked to see them for. All of the medical oncology patients had had surgery, but of course not the haematology patients, and 45% of the whole group had received radiotherapy. Now, the median time from their date of diagnosis was 12 months. However, you'll see that there's a huge range there, and that's driven by a few outliers pretty much, particularly in the haematology, where we were asked particularly to see people who were quite a long way out but really had some very major late-term effects. So the first thing here that we're going to look at is body composition. So for the moment, just concentrate on the red bars, which are what the readings are when people came to see us at that initial survivorship visit. You'll notice that the mean BMI is 28.3. So anything above 25 is overweight. And what we're finding is 64% of the patients are either overweight or obese. We wanted to see what had changed. So in the blue, that is we went back on data where it was available for what the weight and height, the BMI were for those patients when they first attended the cancer centre. In most cases, it's pre their chemotherapy. And what we found was that the average weight gain was 2.5 kilograms. So you might say, well, that's not too bad. However, a third of those had gained more than 5 kilograms. The average BMI increase was 0.85. And in many cases, it was enough to take people from upper category. So say from normal to overweight, from overweight up to obese. Here I'm showing the data for quality of life. So on your right is the total quality of life score. And let me just explain what we've done here. To try and compare it to what it would be in the general population, we've basically devised what's called a T-score. Across the 50 mark, which is where the red line is, this is what the quality of life for total, and each of those domains was for an age-matched Queensland population. This is based on Monica Jander's data. So what you'll see is that the quality of life of our survivors is actually pretty good. It's not far off that for the general population. But if you have a look particularly at the domains of physical and emotional, those are the two most affected, and they are almost one standard deviation below that of the general population. Another question we ask people is their level of distress. They use the distress thermometer to basically give a score between 0 and 10, no distress to extreme distress, for what the level has been in the past week. The mean is 3.5, which again is not too bad. However, the range went from 0 to 10. We also found that 45% scored a 4 or above. And for those of you familiar with the literature, the score of 4 or above indicates that further investigation is required. We were fortunate that further investigation was at hand because of the clinical psychologist. One of the things that she assessed for the patients was their level of fear of cancer recurrence. And she felt that 63% had fear of cancer recurrence. We've only more recently added in looking at what that level is. Like, is it mild, in which case it's probably no big deal, or is it really quite extreme? So we don't yet have that data. However, based on her interview, which, probably takes a minimum of 20 minutes, max of maybe 30, she felt that 42% would really benefit from having further psychology follow-up, and only 9% of those were already having that follow-up. This is what the form that we use for looking at the symptoms. Again, on your left is all patients, and then by the major tumour types. And not surprisingly, based on the previous data we've seen today, and I'm sure based on your experience, fatigue is number one, 43%. And then approximately a third with problems with trouble sleeping, pain, anxiety, paresthesia, sore hands, feet. About a quarter with problems with concentration, irritability, depression, and problems with their memory. And then there's some that are very specific, so hot flushes, obviously much higher in the breast cancer group, 45. The other fairly striking thing is that the levels of, that these are only patients where we've scaled it as where they've reported of at least moderate severity. So this is not just a little bit of mild fatigue, they're calling it at least moderate severity. The scores in basically every single one of these symptoms is higher in the breast cancer group. Finally, looking at exercise, what we find is that these are what the guidelines are. What we find is that instead of doing 150 minutes of moderate exercise, the mean time is 60 minutes of moderate, 52 of vigorous, but the range is from 0, and there's quite a few at 0, up to 840. So only 29% were meeting the Australian guidelines. Finally, looking at their satisfaction with the clinic, it was extremely high. 98% agreed or completely agreed it was worthwhile attending the survivorship clinic. 98% would recommend it to others. Most thought the timing when it occurred was right, but 21% said that it could have been earlier in their journey. And consistently they saw the strength of the clinic as being that it was multidisciplinary. So in conclusion, distress, fear of cancer recurrence, fatigue, obesity, sedentary lifestyle are really common in the cancer survivors that we're seeing, and this is something that's persisting long term. We can certainly identify these problems. We're hoping that with our programs that we can actually do something about it, and we're just looking at longitudinal data now. I'd just like to acknowledge our research team and our funding sources. Thank you very much.
Thank you for a great presentation, Janette. I'm just wondering, there's time for a quick question, if there's anything from the audience. Just a quick question then. I was just wondering with regard to referral to external services from your clinic, have you got any data that you could share?
No, but the main people that we're referring to is the sexual health clinic. We're fortunate to have a separate one for males and females at the hospital that I attend. Occasionally social worker, but that they are our main ones. Yeah.
Thank you.
Thank you.
Thank you.
Oh, it would just be quick, thanks.
Yes, a very quick one. Just thinking of the logistics. Hi, my name's Marianne. I'm a breast clinic in Melbourne. The logistics of coordinating 5 different providers, is that tricky?
It was initially. The hardest thing was getting the right people for the job. We have an absolutely fantastic team, and I think that they sort of look forward to this clinic as it's the only one of its kind where it's sort of multidisciplinary like this. So yes, the coordination initially, getting the funding was tricky, but it's something that we think is working really well, and the staff as well as the survivors seem to really enjoy it or appreciate it.
Thank you.